Welcome to PFT Tutor with Jeffrey Haynes. Please click the like, subscribe, and notification buttons. It's greatly appreciated. In this video, we're going to discuss a topic that doesn't get enough attention: how to properly measure height prior to pulmonary function testing, and how we ensure that the device we use to measure height is accurate. Height is an important demographic to measure because it is used along with age and born sex in reference equations to establish normal ranges for your patient. We often say that height determines your lung size, but that's not technically true. It's not your height that determines your lung size, but your chest dimensions that determines lung size and health. As you can see in these x-rays, you can determine the size of the chest without any legs or any neck or any head. But we don't have an easy way to practically measure chest wall dimensions in the PFT lab, so height is used as a proxy or a substitute for chest dimensions. Height does a pretty good job at predicting chest size, but it's certainly not a perfect proxy. People can have different body types. The subject on the left has a long torso with short legs, so they may have a higher z-score in percent predicted because their height would predict that their chest dimensions should be smaller. The subject on the right has the opposite effect. This subject has long legs and a short torso, so they may have lower z-scores and percent predicted because their height would predict that their chest dimensions should be larger. Sometimes I'll make note of this in my report if the patient is near the lower limit of normal and might get misclassified because of their body type. The same effect can happen because of neck length, since a longer neck may make you taller without having any relationship to your chest dimensions. Despite all of its imperfections, we do need to measure an accurate height, and there is one thing that is clear. Self-reported heights from patients are not reliable. Most people think they are taller than they really are. In my experience, this is especially true in adult men. This is a study that was published in the journal Obesity, comparing measured height to self-reported height in 3 different surveys conducted over many years. The solid line shows the measured heights, and as you can see for both women and men, the self-reported height is consistently higher than the actual measured height. To measure a patient's height, you'll want to use a stadiometer. A wall-mounted stadiometer is recommended, but you may not always have that. And you want to measure the height in stocking feet, not wearing their shoes. Occasionally you may come across a patient who has a difficult time getting their shoes on and off. So one thing you can try is to use a tape measure and measure the height of the heel and subtract it from the total. Not an exact science, but something you can try. When measuring a patient's height, it's also important to pay attention to their posture. Many patients will be slouching, not standing up straight, so instruct them to stand up nice and tall. And you'll also want to pay attention to how their head is positioned. So you want to use what's called the Frankfurt plane. So the plane from the eye to the ear should be parallel to the floor. The United States is still one of the few countries in the world that doesn't officially use the metric system. So in a lot of U.S. labs, you'll see height reported in inches, but it should be measured in centimeters reported to 1 decimal point. There are some patients in which standing height is misleading or not possible to measure. For example, if a patient has significant kyphoscoliosis, standing height may give a misleading view of what their lung size should be. And there are also patients who have neuromuscular disease in which standing is not possible or safe. So for these patients, you can use arm span to predict standing height. The relationship between height and arm span is not 1-to-1, but your PFT software should be able to make the proper calculations. Measuring arm span may also be difficult, especially if you're alone and you're trying to measure this with a tape measure. Some patients may not be able to straighten their elbows or lift their arms due to shoulder issues. So the other method to use is the ulna length, shown here, which is actually more accurate than arm span, and it is the recommended method for young children. Calipers are recommended over a tape measure, and just like arm span, your PFT software should be able to convert the ulna length to height. In the PFT lab, we spend a lot of attention on making sure that our spirometers and lung volume and diffusion devices are all calibrated and accurate, but we don't spend much attention on making sure that our stadiometer is accurate, especially if it's not wall-mounted. These devices may become jarred from being moved around for cleaning, or maybe were never even properly set up correctly from the start. As you can see in this picture, that the stadiometer is off by over 2 centimeters. We keep a measuring stick in our pulmonary function lab. You can go to any hardware store and just cut one yourself. Ours is 65 inches or 165 centimeters, and this is our standard for making sure that the stadiometer is accurate. So I will periodically test it to make sure it is accurate. Sometimes patients will question the accuracy of our stadiometer because they think they're taller than they really are, and you can just grab this and just show to them that the stadiometer is correct. Stadiometers are becoming more sophisticated. There are digital types now. In our lab, we have more basic stadiometers. So I put this little level on the headpiece to make sure that it's level, both when I'm making a measurement with a patient and also testing it for quality control. As I said, our measuring stick is 165 centimeters, and you can see here that the stadiometer is pretty much spot on. Then I just add a little label to the headpiece showing when the last time it was checked, and that can also help with a patient who's questioning it. I can say, well, I just tested it 2 days ago. Key points: height is a key demographic used in reference equations, but it's really a substitute for chest dimensions. It is very important to record an accurate height prior to pulmonary function testing. Alternatives for standing height should be used in patients when standing height cannot be measured or is affected by spinal abnormalities, and it's very important that stadiometers be verified periodically as part of your quality control program. Thank you for watching PFT Tutor with Jeffrey Haynes. Please click the like, subscribe, and notification buttons, and we'll see you next time.